started producing, the cost came down. You see the red line. And as the cost came down, people who said, why should I go for a test? Even if I test myself and find I'm HIV positive, I cannot afford any treatment. They started coming, and you'll see the lines, the blue line, numbers who started coming to us faster, and those who started enrolling for treatment. And this is the rollout in India. A total of about 4 lakhs people are under treatment with the government of India. But there are a number of challenges in starting people with HAART is highly active antiretroviral therapy. Patients present for care late, like I told you, they don't know they're positive. They've had sex when they were kids or students in college, and they've forgotten about the whole thing. And after 20 years, they develop TB. And then they say, why is this young man having TB? And then they test him for TB, and then say, why not look for HIV? And they find he's positive after 20 years. So that's how we find people with HIV. So those who are at risk should go for a test early, because if they come early, we can definitely give them a good quality of life for the next 30-40 years. Improved access of therapy, we need adherence. We were discussing in the biotechnology department about adherence. In India, the custom is people take medicines. When they feel better, what do? You stop. And if you stop, what does the virus do? It develops resistance. And then you're stuck with the resistant virus, which is not going to listen to your first-line drugs. You have to go to second-line drugs, more expensive and more toxic. So it is important that we talk to patients about drug adherence for the rest of their lives. Once they start, they have to take it for the rest of their life till we find a cure or a vaccine. Otherwise, you get resistance, and sometimes you have co-infections with TB, with the hepatitis virus, which makes treatment much more difficult. For those who are in microbiology, diagnosis of HIV, in the very early stages, we only did clinical diagnosis. You saw something like this, you said it was. And then we got on to ELISA testing. First generation ELISA was just for testing, and we had to wait 3 months, 6 months before the test becomes positive. And then we got the second, third, fourth, fifth, sixth generation, where you can pick up the infection within about 4 weeks of the person developing the infection. And then we got the Western blots, you have rapid test, and now today we have what is known as the DNA PCR. So if there is a baby born to HIV positive mother, and they want to find out is the baby infected, all you need is to do the DNA PCR. If it's negative, the baby is negative. And then you don't breastfeed the baby, and the baby is going to be negative for the rest of the child's life. So it is very important to know about these tests. Now, when you start treatment, you need to monitor. So what are the tests you do in the laboratory? Earlier, we only did clinical monitoring because we had no test. Then we did the hemoglobins and the total lymphocyte counts, because that was enough to tell us that immunity was high or low. Then came in the CD4 counts. Now there are different machines by which there are small CD4 machine, you can carry it in your hand, go to rural areas where people are infected, take a drop of blood and test and tell them on the spot what their CD4s are, so that you can continue the same drugs, or you may have to change if the CD4s are not rising. Then you can do a viral load test, count the number of virus particles in an ml of blood, and if it is undetectable, you know the patient is doing extremely well. And lastly, you have the resistant testing. That is, if the patient is not responding properly, you know the patient has not taken the drug properly, or the virus has mutated and become resistant. So all these tests can be done, and those who are interested to learn these, you can come to our center as an intern and you can do the testing. So testing for research purposes, we need to know the incidence. Do you know what the difference between a prevalence and an incidence is? Yes or no? No? Prevalence is let's say you have 200 people here, 150 people here. You test them all and you get 5 positives. Then we say the prevalence in this room is 5 for any infection. Incidence is new infections. We don't know out of these 5 how many are new, how many are old. When you got the infections, you don't know. So that the new infections are known as incidence. So incidence testing is important when you start a prevention project. You want to know, are the new infections coming up or no? Because HIV, once it enters the body, it's going to be positive for the rest of your life. So you don't know it's new or old. So that is the incidence testing. We do what is known as the P24, or it's known as a BED assay, which we can do, or an avidity testing. To explain, it's going to take a long time, so I won't go into this. Or you can do a single copy assay. Now when we see a patient and he's been taking drugs for a long time, and his viral load is undetectable, you don't know it is there. There was a baby in US called the Mississippi baby. Have any of you read about that? Now this baby was born positive, was given drugs the minute the child was born. The next day they started treatment, and after 18 months they found the baby was cured. That's the only case in the whole world. The baby was cured, and that's known as the Mississippi baby. So in such cases, we want to look for one single strand of the virus. You do what is known as single copy assays. And then you have to look for the reservoir of the virus in the lymph glands or in the brain, for which you do a latest reservoir activation assay. Or phylogenetic, to link, is this person got the infection from the same person? For example, couple gets married and the woman is positive and the man is also positive, and the man says, I got the infection from the woman, and the woman says, no, he gave me the infection. Now how do you prove that? And you can do it by phylogenetic linkage analysis. So we were doing all this service to patients, but not much research. Because just like you, we didn't have much things to do, we didn't have money. So we found this girl. Her grandmother was in Chennai and she was working in Brown University. So she came and found our YRG center, and she walked in and she said, oh, you do some HIV work here. I will introduce to my professors who want to collaborate with some center in Chennai, in India. And these are the great men. Dr. Carpenter is the man with the maximum experience in HIV in the US. And then Dr. Ken Mayer and Susan Coogan and Tim Flanagan. So we started working with them and our research started blossoming. The first research were in children, because those are the groups which really need help. So we have roughly we used to have 500 odd children who are HIV positive. You need to keep them cheerful, more important than giving them medicines. They need to enjoy life. So we used to have Camp Rainbows for them. And this is the number of children who are positive, those who went on treatment. We helped them with education, nutrition, etc. And then we started our ID lab. So from one kitchen, we moved to a lab called the YRG Care Infectious Disease Laboratory, being inaugurated by Dr. David Celentano from Hopkins and Ken Mayer from Brown University. And today we have, I would say, the best lab for HIV in India. We have every specimen. You'll see the first one is deep freezers, where we save all our samples. we must be having more than about 400,000 samples saved. The first deep freezer I bought was a second-hand deep freezer because we had no money. And to keep it closed, I had to keep bricks on them. The ones now we have, about 15 of them, are brand new, minus 80. And if you want a sample of an individual, you just give us the number, and within 45 seconds, it will be picked up from whichever deep freezer, because you have what is known as LDMS. You need all this when you want to do research in a large scale. So we have specimen storage, microscopy, hematology, biochemistry, microbiology, TB diagnosis. We have a gene expert now, molecular biology, real-time PCR. We are a genotyping center for the Southeast Asia. All the samples from the southeast of the world comes to us for testing, and our lab is accredited by the College of American Pathologists, UK NICOS, and by NABL. It is also recognized for PhD, and these are the first 4 PhD students. It's affiliated to the Madras University, and then we built the second floor because we all wanted to be in the same block. So the second floor was donated by the Tamil Nadu Foundation from San Francisco, where we have a training center. Then, like I told you, we have our matrimonial service. So if a man is HIV positive, does he go and tell his parents? No. Because he is worried, the parents will get worried. So everybody is worried, but the parents want the boy to get married. So they start looking for girls, and he comes to us, and we say, no, you can't get married to someone who's negative. So this was the first marriage we conducted. Murthy was an engineer, and he was pressurized by his parents. So he turned to support to IRG Care. His CV along with his photos were circulated to other NGOs working in the field of HIV, and we found Bhavana. So Murthy flew to Mumbai and met Bhavana, who knew only Marathi, and Murthy knew only English and Tamil. So how do they speak? Do you need a language for love? So love blossomed, and they got married in 2 months. They have a beautiful son called Akash, who's now about 12 years old, HIV negative, both parents positive, and both parents don't know that their children are positive, even today. So they lead a normal life. So this is what you can give to people who are HIV positive if you help them. Otherwise, they would go and marry a negative girl, spread the virus, the girl will go to the High Court, put a case on the man, and there will be total chaos. So that is why we started doing this. The next problem in India is, after you get married, you should have good news. No babies? So fertility was the next problem. So there, here's Revati, who in Tamil Nadu, they normally marry their uncle, the mother's brother. And so she had to marry, though he was HIV positive. So she came to us, we did an IVF for her, and she has a little baby, Aarti. She's negative and the baby is negative. The man is positive, is on treatment. So we can solve problems that way. Then we opened up a community research facility because we started working on HIV vaccines, domestic violence, mucosal immunity, because there are some women, in spite of repeated exposure to HIV, don't pick up HIV because they have an immunity in their vaginal mucosa. So that's another major project we are doing to find out. We also do a lot of telecounseling services. Do you recognize this guy? Richard Gere. He's been a couple of times to our center, and he opened this, and he also works with the refugees from Tibet who come into India, and we help him out with all the TB those people have in These are some of our research projects. This is a big research project funded by the Global Fund. You must have heard of Global Fund, which is to give antiretrovirals to patients on a sliding scale. So the rich pay for the poor. The rich pay 100% and the poor is 0%. In between you have 75 and 50, and we allocate in this way, and roughly about 3,000 patients were enrolled in this. And then we have a center in the north of Chennai. It's known as Caesar, and that's where we take care of drug users. Now these are drug users waiting, the blood being drawn from drug users, being examined, and roughly about 1,300 drug users being taken care of. And these are the different projects, research projects with them in collaboration with Johns Hopkins University. This is liver disease and HIV, and this is one of the very few fibroscan machines in the country we have to find out how much fibrosis is present due to these different infections. We work with the police, with the prisons. You can get almost anything in the prison and they need a lot of help. Mother-to-child transmission. So if a woman is HIV positive, does the baby get the virus? Yes or no? Yes, no. No. You can stop. And so the first research was 076, where you gave the mother antiretroviral drugs known as zidovudin, and that prevented the transmission by about 30%. Then we started giving a single dose nevirapine at delivery, stopped the transmission by 50%. Today we do what is known as B+, that is the mother gets the full heart right from her second trimester and the babies are born negative. Also, she mustn't breastfeed the baby because the infection can spread through the breast. She'll have to put the baby on formula food. So this was the USAID project given to us, where roughly about 15,000 women we had screened. We had about 900 HIV positive women, and almost all babies were born negative. This was only 3% babies who were HIV positive. We helped the Tamil Nadu government with the community care center. We also do help to pull out the sex workers and make pie bags. So this is the tailor who's teaching the sex workers how to make these bags, and these bags are then sold. These are the bags they make, and these are sold.